Hello, my name is Andrea Plawecki, and I'm a PGY5 otolaryngology resident at Henry Ford Hospital. The title of my project is Clinical Features and Headache Diagnoses in Patients with Chief Complaint of Craniofacial Pain. This project is the result of collaboration between our otolaryngology and neurology departments, and I would like to thank my primary mentor, Dr. John Craig. The authors have no disclosures. Craniofacial pain, often inaccurately referred to as sinus headache by many patients and clinicians, is one of the most common reasons for outpatient otolaryngology referrals and represents a diagnostic and therapeutic challenge. Facial pain is well known to be one of the cardinal symptoms for the diagnosis of rhinosinusitis, as shown here in the Academy of Otolaryngology guidelines on the top right. The International Headache Society has also developed criteria for diagnosing headache attributed to sinusitis in the bottom right. Similar to otolaryngology guidelines, they highlight the need for objective evidence of sinus infection or inflammation. There remains no clear consensus for the best way to determine whether facial pain is or is not due to rhinosinusitis. It has been shown that symptom-based criteria alone yield low positive and negative predictive values, highlighting the importance of objective findings. Sinus CT has been considered the gold standard for evaluating sinusitis, but studies show poor correlations between facial pain location and site or severity of disease on CT, as well as a high prevalence of incidental findings. While it has not been established to be superior to CT, nasal endoscopy may be just as effective for objective evaluation. It's also been well reported in the literature that the majority of patients presenting with self- or clinician-diagnosed sinus headache meet criteria for diagnosis of other non-sinogenic headache disorders, most commonly migraine. Also, multiple studies have shown that patients may even have coexisting sinusitis and headache disorder diagnoses. It is important to determine the best way to evaluate these patients in order to limit unnecessary treatments, patient suffering, and healthcare costs. The purpose of this study was to determine headache diagnoses and clinical features like sinonasal symptoms, nasal endoscopy, and imaging findings in patients presenting to a rhinologist with a chief complaint of craniofacial pain. This was a prospective observational study of 134 patients presenting to a rhinology clinic with chief complaints of craniofacial pain. The data we examined included headache diagnoses made by neurologic subspecialty certified headache specialists, sinusitis symptoms, sinonasal outcome test scores, pain location, nasal endoscopy findings, and imaging findings. These were the reported locations and lateralities of facial pain or headache for the entire group. The most common anatomic subsites reported were cheek and forehead, and 2/3 of patients reported bilateral or midline pain. Patients in the group underwent nasal endoscopy, and about 90% were found to have negative nasal endoscopies, with only 10% having objective evidence of purulence, polyps, or edema. Our mean patient age was 50 years, and 75% of patients were female. We looked at symptom frequencies and scores in patients, as well as a comparison between patients who had positive and negative nasal endoscopies. Patients with positive endoscopic evidence of sinusitis were significantly more likely to report accompanying symptoms of nasal obstruction and smell loss. Conversely, the presence of isolated facial pain was found to be more prevalent in patients with negative nasal endoscopies, and this finding trended towards significance. SNOT-22 scores were similar between groups. Patients met criteria for a wide variety of headache diagnoses made by neurologic headache specialists, and the majority of which were migraine and tension-type headaches. As you can see, only 5% of patients in our group were diagnosed with headache attributed to rhinosinusitis. About half the patients in the group had CT scans of the sinuses that were reviewed by the study authors, and individual sinus findings were coded as either positive or negative. Cohen's kappa analysis was performed to assess agreement between reported pain location and CT findings by sinus location, and this generally demonstrated poor agreement. We also assessed for agreement between endoscopy and CT sinus findings, and this picture is an example of concurrent negative findings. We found that negative nasal endoscopy showed high concurrence with negative CT findings in the sinuses corresponding to the drainage pathways visualized endoscopically. We also assessed for agreement between CT and MRI sinus findings in patients who underwent both imaging modalities based on headache criteria. The example here shows near perfect agreement. In these patients, we found substantial agreement between sinus findings in patients who underwent both imaging modalities, with kappa values generally ranging around 0.7 to 0.8. So, potential neuroimaging for headache workup may obviate the need for CT in some patients. In conclusion, patients who presented with chief complaint of craniofacial pain generally met criteria for various non-sinogenic headache disorders, especially migraine and tension-type headache. Sinus CT findings demonstrated poor agreement with craniofacial pain locations. Nasal endoscopy was negative in 90% of patients and demonstrated high concurrence with negative CT scan. This study suggests that, in the setting of prominent facial pain and negative nasal endoscopy, neurologic evaluation can be considered rather than upfront sinus CT. Thank you.